Okay, now we are recording. So obviously, and I just want to check, guys, you all are just seeing, like you're just seeing the PowerPoints, right? You're not seeing the, what the PowerPoint calls the presentation thing where there's like a timer running and all of those things. Y'all just see the slide, right?
Yeah, it's just the PowerPoint.
Okay, perfect. Thank you. So the real question that we're going to have out of all of this, guys, is all of these things are going to change with age. So we need to kind of now define what does it mean to age, okay? And how many of that vast, huge list of things that are going to change, how many of those are inevitable, or to what extent are those changes inevitable? And then to what extent can we play some role, okay, however small, and in preventing or attenuating some of those changes that may sort of take place, okay? People don't talk about this very much, I don't think. And there's a host of reasons why that's going to be the case. But aging is a really big deal. Aging affects a huge number of people. We can argue that we are all aging at all times, right? Like you are now older than you were 5 minutes ago, which is kind of a mind-blowing experience for me. But the reason that we need to really care about aging, we need to care about the changes that take place with aging, is that as a population, the United States, we're shifting sort of our population so that a larger and larger percentage of it is going to be people that are considered older adults, okay? So what we think is that by 2030, so in about 10 years, about 1 in 5 people in the US will be 65 or older, okay? So there's this generation that are my parents, or the folks that are kind of probably in the age between your parents and my parents. They're called the baby boomers. These are mostly people that were born in the late 40s and in the 50s, and what we're calling the baby boom post-World War II. Many of whom are aging into this 65 and older population. And so what you guys will see is that we are living longer as a group, which is a good thing. But the consequences of some of that is that we're getting this larger and larger bolus of people that are going to be 65 and older. So we need to pay more attention to diseases and issues and disabilities and things that are going to potentially adversely affect folks as they age, because a larger and larger percentage of people are going to be that age. And so if you can live longer, that's great, but you also want to kind of prevent these diseases and maximize quality of life, okay? And so regardless of what you guys are going to do in your lives, many of you in the allied health professions are going to come into contact with lots and lots of older adults. So we want to care about and understand how all of this happens. Okay, so here we're going to have the percent increase, and these are some data from the CDC, the percent increase in the portion of the population that are 65 or older, okay? From 2003 to 2013, it's broken down by state. And so what you can see basically then is that the darker blue states are going to have a larger increase in people that are older. The lighter blue states are going to have a smaller increase. And so there's lots of kind of interesting demographic things, like basically every state is getting this increase. Older adults tend to congregate now and move into what we would traditionally call sort of the Sun Belt states, which now is becoming sort of Arizona, Nevada, Texas, and Florida. We like to move to warmer climates and things, but you can see that basically every place has this kind of relatively dramatic increase. So when we talk about the changes that take place in with aging, we're going to break this down by physiological system, okay? And so when we talk of the motor system, what we're really meaning is the neuromuscular system. So brain, central nervous system, peripheral nervous system, and then skeletal muscle, okay? And so there are some fairly profound changes that will take place in the motor system, and they're going to have a big impact on mobility, balance, and coordination and strength and kind of how people can get up and get around and do things. Okay. The big change that takes place in the neuromuscular system, and the one that in many ways drives these changes that we see in everything else, is this first one here. Okay. It's the decrease in muscle mass and the associated decrease in muscular strength that occurs as we get older. Okay. So for most of us, okay, you guys probably have about as much muscle mass and about as much strength right now as you're ever going to have in your entire life. Okay. That is especially true in men. It's especially true in men that potentially played sports and things in high school, but maybe not in college, because they tend to kind of decrease their resistance training once they sort of reach that college age, and it's going to begin to kind of decline over time. The evidence in women, especially more of late as resistance training has become more and more popular in women, is not quite as pronounced a decline right after kind of typical college age. But generally, you guys have about as much muscle as you're ever going to have, and the job from now on is just to try to retain and hold on to as much of it as you can. Similarly, with strength, most of you are probably about as strong as you're ever going to be in your life. And so now the changes and things that are going to occur, it's going to come down to how much of this can you hold on. Because as mass decreases and strength decreases, then muscular function also is going to decrease. Okay, your speed of movement, your dexterity is going to decrease. You're going to have decreases in disability. You're going to have increases in falls that are going to occur. So basically, as you lose mass and strength, everything is going to decline after all of that. Your ability to walk, your ability to run, your ability to do other kinds of exercises and things, all of that is likely going to change. Now, for most of you, okay, you are not going to see noticeable changes in these things probably into your 30s or maybe even into your 40s. It all depends again on how active you were in high school and as college age, and then how active you continue to be moving on. So we'll talk a little bit about the ability of all of that to kind of mitigate some things. Okay, so the reason that we need to care, okay, about decreases in strength and decreases in muscle mass is that there is some critical level of strength that we need, okay, to be able to undertake, let's just say, normal daily physical activity like walking up and down stairs, getting into and out of the bathtub, carrying groceries, all of the things that you normally do in a given day. Okay, that doesn't necessarily mean that like you're going to go rock climbing or that you're going to go and you're going to do CrossFit or some kind of sprints or something else, but just for normal daily activities, there is some critical amount of strength that is required based upon your body weight. Okay. And so what you can note here, okay, is in this particular graph on the left, we have age down here on the y-axis, or on the x-axis, excuse me. And we are going to assume, okay, that here at about your kind of early 20s, at about where you guys are now, you're approximately as strong as you're ever going to be, okay? And then what the y-axis is trying to show is the percentage of maximal voluntary contraction, okay, compared to where you were at age 20. So this is making the assumption that right now you're about as strong as you're ever going to be, and then your leg strength is going to steadily decline over time as you age, okay? Now, we can argue, and I'll show you some data like over here, we can argue about kind of what is the shape of this curve and the speed with which, or the slope of this curve, and the speed at which things are going to decline. But in a very general sense, you're going to get weaker. Okay, so if we accept all of that, what you see here in the kind of pinky red, kind of flesh colored area is this is the percentage of your strength, of your maximal strength, that is going to be required to go from sitting to standing. It says standing from sitting. So what that means is you were sitting down and now you need to stand up. So I'm sitting in my office chair. How much strength do I need to be able to stand up from a sitting position, which is one of our hallmark markers or hallmark measurements of whether a person can live and function by themselves. Okay? Getting from a chair up to being able to stand up is not going to seem like that big of a deal to you guys. It shouldn't. Okay? But for older adults, as you guys will see, when your strength declines to a certain point, it can and will become very, very difficult. Okay? And so the top portion of this box is going to denote going from sitting to standing very fast. And then the bottom portion is going to denote going from sitting to standing very slowly. Okay? So if you remember the shape of from way back of the force velocity curves, that we know that when we go very fast, our muscles are able to generate a little bit less force than they are when we go very slowly. So I need greater kind of maximal force capacity to be able to go fast, because I'm losing some of that force when I go fast to stand up quickly. Whereas if I go slower, then I can call in a greater proportion of my maximum strength. So there is this zone in essence, okay, where based upon your body weight, and this is assuming that a person maintains their kind of normal body weight, which we already have talked about is not going to happen, okay? All of us in general are going to add 20 to 30 pounds from the time we are basically 25 to 45. So if you weigh more, you're going to need more strength to move. But there's some critical amount of force or percentage of your maximal strength at 20 that you need to be able to go from sitting to standing. And the problem arises when your maximal strength has declined to such an extent that you can no longer do this quickly, or you can no longer do it at all. And that's going to mean then that if you can't get up out of a chair, that you're going to need assistance. And that may mean that you need to go to an assisted living facility. You may need to have someone come and stay at your house, or you may need to move in with family or something like that in an effort to have them help you out on those things. And as we have seen, right, in the best of times, that's not always a great deal, as we have seen with COVID and things, that COVID tends to be particularly rampant in assisted living facilities, right, in nursing homes, in places where people are more confined in kind of a close area. So not so great. You all don't think about it now, but at some point your strength will decline. Okay? So under the age of 60, we tend to see about a 10 to 20% decline in strength per decade. So it's not a huge amount, but it's about 10% per decade. And that's going to then accumulate over time. So by the time you're going to get into your 50s and your 60s and your 70s, there may be real consequential deficits that are going to take place. And after the age of 60, there tends to be an even greater or more accelerated decline in strength. Some of that is due to hormone loss, some of it's due to further kind of inactivity and things like that. What you can see here in the right panel with everything is in blue, we have men that were strength trained when they were young, and then continued to do some level of strength training as they began to age. And then we had men that were untrained and stayed untrained. And so what you will note is that both groups began to see some level of decline after the age of 30, but the slope of decline was a little bit steeper in my untrained men, but also because my strength trained men started off at a higher percentage, okay, at a higher strength level, even as they began to decline, they were still in general stronger than my untrained men. So having more strength to be able to lose before you get to that critical value to be able to move around and sit and stand and those things is going to be better. Okay, so a lot of this strength loss is due to a loss in skeletal muscle mass. Okay, and so the age-associated loss of skeletal muscle mass is called sarcopenia. Okay, it's called sarcopenia. Some people will talk about sarcopenia being a disease in and of itself. There is some debate, that the real issue that I want you guys to know is that this is age-associated decline in muscle mass. Okay, and so what you can see in the left here is an MRI image of a relatively young, healthy person, okay? Here we're going to have their knee extensor muscles here on the top. Remember, we're looking up through their legs. This is a person's right leg. You're looking up through their heel, up at their legs. You've got vastus lateralis out here. This is rectus femoris. Vastus intermedius is here, and then this is vastus medialis. Hamstrings and whatnot down there. Okay, this is the inside. This is the outside. There's their femoral artery right there. Here is, and this is a relatively lean older person. You'll note this is subcutaneous fat out here. They're still very, very lean, but their muscle is smaller. And you will note that there appears to be a greater marbling effect in here. So there's been this infiltration of intermuscular fat that has taken place. So there's an increase in fat, there's an increase in connective tissue. So why does muscle mass decrease with age? This is the really, really key question that we have to understand. Okay. Part of it is due to a decrease in the size of individual muscle fibers. Okay. As we age, okay, our especially large, strong, weight-bearing muscles tend to be more susceptible to sarcopenia because, in general, we tend to become less active, okay? And when we are active, we are doing lower force, lower intensity activities. We are not doing squats, okay? Or if we do squat, we are not doing heavier resistance squatting that's going to help us maintain or increase muscle mass. Okay, so we're going to get a decrease in the size of the fibers that we have. Okay, the other issue that occurs with aging is that there is also going to be a decrease in the total number of muscle fibers in skeletal muscle. So some of your muscle fibers are going to die. Okay. And a lot of this is due to an accumulation of neurotoxin in the spinal cord that's going to kill off the alpha motor neurons that connect to those fibers. And when the alpha motor neuron dies, then those individual skeletal muscle fibers that were connected to that motor neuron are also going to die. Okay? I imagine that in exercise physiology class, Dr. Mike will talk more with you guys about something called the neurotrophic effect of the connections between motor neurons and individual muscle fibers. But you need both, and you need to contract those muscles to keep both the motor neuron and the muscle fibers healthy and intact. Okay, but the individual fibers that you have are going to get smaller, and you're going to lose some, and you lose any ability. You're born with all the muscle fibers you're ever going to have, so you lose the ability to kind of get those fibers back, and so you're going to lose muscle mass because of that. Okay. Okay, so I should also point out with this is that this also tends to be, with sarcopenia, is that you're losing muscle mass, but this also tends to accompany an overall gain in body weight, okay? And so I'm gaining fat, I'm gaining connective tissue and things, but I'm losing muscle mass. And so it's kind of this double whammy that's going to get put on with everything, okay? If we look at things from a time course perspective, okay, you tend to lose strength, okay, sooner than you lose muscle mass. Many of you will begin losing strength. Some of you have already begun to lose strength from whatever your peak strength was, whenever the last time you were doing resistance training was. If you stop doing resistance training, you're beginning to lose strength, within days from doing all of that, okay? So very often it takes into your 40s or your 50s before we really, really see kind of noticeable losses of muscle mass, or we would think of as sarcopenic loss of muscle mass. The decrease in strength tends to happen by your mid-20s or 30 or thereabouts in a lot of people, okay? So loss of strength is going to come from decreases in activity, decreases in kind of high force activity. Loss in muscle mass is partially driven by decrease in activity, but it's also going to be driven in a lot of instances by changes in or loss of estrogen with menopause and loss of testosterone when we go through andropause, guys, which may occur in anywhere between your mid to late 40s into your mid to late 50s. It's going to vary from person to person. Okay. Weirdly enough, one of the things that we did in lab The grip strength test is one of the gold standard screening tools for deciding if somebody is experiencing sarcopenia. Okay? So the idea behind all of this is that sarcopenia, this loss of muscle mass with age, is going to occur systemically. So every muscle in your body is going to begin to lose mass as you age. And so grip strength, or doing the squeezing exercise, is going to be a relatively cheap and a relatively easy way to assess all of this. Okay. So there's lots of data on changes in grip strength with older individuals. We can argue about whether or not doing leg press or some kind of locomotor muscle, plantar flexors, dorsiflexors, knee extensors might actually be a better predictor of changes in function and changes in free living ability. But grip strength, we have a lot of data on, and it tends to be a relatively good screening tool. Okay, so it's one of the reasons that we do it as part of our lab, as you guys can see those things. Okay, so not only do you lose size of muscle fibers, and not only do you lose individual muscle fibers, but one of the bad things about that loss of muscle fibers is that the ones that you tend to lose are very often going to be, they're going to be type 2 muscle fibers. And so if we look at older adults, and here are some old data that are here, but we have nothing to refute this now. If we look at people, and these are a group of folks that were tested in 1974 and then tested again in 1992, and so in 74, most of these people were in their 30s, and then in 92, they were in their 50s. Okay. What you will note is that the higher this bar gets, the taller the bar, it's going to show us the greater the percentage of all of your muscle fibers that are slow twitch. Okay. And so what I want you guys to note is that people that were highly trained, they were highly trained in the mid 70s. These were actually, for the most part, they were like Olympic distance athletes. They were nearly 70% slow twitch. And this group tended to stay very, very active, and so they didn't see much of a change. Okay, a very small but not much of a change in their fiber type percentages. We look at what we're calling fitness trained, so kind of folks that are like most of you guys, I would imagine, or like I was when I was in college and even a little bit after. Folks that did a fair amount of aerobic and resistance exercise. They were not nearly, they were kind of very close to 50-50, type 1 to type 2 to start with, but you will note they went from about 55% type 1 up to about 65%, so about a 10% shift. And then you look in the untrained folks and you saw a relatively similar shift, about a 10% shift. Okay, what this is telling us is two things. Okay, this is happening because of two things. One, the motor neurons that seem to be the most susceptible to an age-associated accumulation of neurotoxin from food and other things that we tend to ingest year over year over year seem to be the motor neurons that connect especially to type 2X muscle fibers. Okay, so the largest motor units, the fastest, the most powerful, the kind of strongest and fastest, the most powerful muscle fibers and motor units that we're going to have are the ones that we tend to lose with age. Okay, so this provides sort of a double whammy. I'm losing big motor units that generate a lot of force and are able to generate it very, very fast. So not only do I lose strength, I also preferentially lose contraction velocity or contraction speed. This is why grandma and grandpa aren't very good sprinters. This is why grandma and grandpa have reaction times that slow down. Okay, they are losing not only strength, but they're also losing some of the skeletal muscle phenotype that is going to provide them with speed and power. Okay, another interesting thing that happens as you lose some of those motor neurons and some of those muscle fibers die, you will also get a shift where the axons of the intact motor units are going to branch off and try to go off and reconnect with those muscle fibers before they've died that have lost their innervation. And so this is called collateral sprouting or collateral reinnervation. And so a consequence of this is that some muscle fibers don't die. They get rescued and they get integrated into other motor units. But what happens with that is that a lot of them, the motor units that are going to reach out and grab those old muscle fibers are going to come from type 1 or slow twitch motor units. And it's going to turn those muscle fibers from type 2X muscle fibers into type 1. So even though I'm saving some fibers from death and going away, they're now shifting to be smaller and slower muscle fibers. So I get this kind of double whammy of sorts on all of this. And that is why the fiber type percentage seems in older adults to shift more and more towards type 1. It's because of this collateral reinnervation. As the type 2s begin to die off, some type 1 motor units are going to reach out and try to rescue them and then turn those fibers into slow twitch. Okay? So that should be good from an endurance standpoint, which in some instances it is, but it's not good from a strength and a power standpoint, which is one of the things that really tends to affect older adults. Okay. Now let's talk about aging of the skeletal system. So several of you guys mentioned things and changes that may take place in the skeleton, and we'll talk much more so about some of these changes on Wednesday. Okay, we'll talk about musculoskeletal disorders. We'll talk a lot more about osteoporosis and arthritis and things that can affect the skeletal system. But the primary change in your skeleton, and this is going to be, it's going to happen in both men and women, but it's going to be much, much more pronounced in women than it is in men, is a decrease, an age-associated decrease in the amount of minerals, especially calcium, that is going to be in your bones. Okay, so this decrease in bone mineral density is termed osteoporosis. And so as your bones lose their minerals, as they lose the calcium, as they become less dense, the bones become more brittle, they become more porous, and it's much, much easier for those bones to break. And so it requires much less external force applied to them for them to fracture. And so, you know, that's why when older people fall down, they break things. They break a hip, they break the femur, right? They break their wrist a whole bunch because they fall and they land and they brace themselves, and they break the wrist, okay? So that's kind of what happens with these two first things. Bone mineral density goes down, that increases your fracture risk. This is further exacerbated by the fact that you lose strength, and because if you lose strength, you lose balance. And as I lose my balance, I'm going to fall over more so, okay? There are going to be changes in connective tissue. The collagen loses some of its elasticity, so that's not great for ligaments and tendons, okay? You tend to lose range of motion in your joints, which is one of the things that I can definitely attest to. It tends to really affect things like in your back, and your hips, and your knees. And some of that you can combat some of that with stretching and things like yoga and exercises like that, where you're going to try to keep all of those things healthy. Part of it can't be prevented because you're going to develop bone spurs, and you're going to develop actual kind of pathologies in those particular joints that are going to either limit your range of motion because it hurts, because it's painful, or there's going to be more physical kind of interaction between those bones, and that's going to limit your range of motion. You lose elasticity, therefore your tendons are going to become more stiff. As they become more stiff and less elastic, then there's a greater risk that when you apply force to them, they're not going to be as stretchy. And so again, it requires less force, either shear force or twisting force or something to them for you to have a tendon or a ligament injury. So it becomes much easier to damage an ACL or an MCL or something, or to explode your Achilles tendon or something like that as you age. The vast majority of all of this, okay, the vast majority of this is simply due to disuse. Now, as we'll see on Wednesday, some of the changes in bone density, some, not all, but some, really can't be prevented, especially in women. As estrogen declines through menopause, then we really have to ramp up the exercise stimulus. in order to kind of prevent full-on development of osteoporosis. It becomes much more difficult for us to do all of that because estrogen plays such a key role in helping to regulate the deposition of calcium into bones. Okay, but a lot of the stuff about elasticity and range of motion and these things, a lot of this we can stave off a bunch of it simply by staying active or simply by staying more active as we age. So we've talked a little bit about things that are going to happen in the nervous system, especially in the central nervous system. Due to lack of blood flow and especially neurotoxins, the accumulation of both of these things leads to something called apoptosis, which is programmed cell death. So cells accumulate toxins, so they're like, we're just going to die off because of that. They don't get enough blood flow, so they're going to die off because of those things. We're going to have decreases in neuron number. In the spinal cord, for sure, with alpha motor neurons, and then in some limited instances, like if you've had a stroke or something, there may be more changes in the brain and other kind of higher central nervous system areas. Part of this is going to lead to decreases in reaction time. Okay, so there's a neural side of a decrease in reaction time as well as the physical kind of changes and loss of type 2 fibers. They're going to do all of that because we're sending decreased sort of speed of transmission within the nervous system. You may lose myelin on some of our axons in places, which slows down conduction. And so all of this together, you're going to become less coordinated and you're going to have less coordination and dexterity. Okay? So you're going to lose a lot of your fine motor skills and things as we're going to age. Much of these changes in the nervous system can be prevented by simply maintaining activity and maintaining use of those neural pathways. Okay, it's one of the reasons why doing crossword puzzles and Sudoku and things like that is really good for keeping people mentally sharp. Is that you are making those neurons in your brain fire, and it helps to maintain those connections. In a similar way, making and using those neural pathways that are going to lead to muscle contractions and things where you're going to need fine motor skills or even gross motor skills, things like walking, running, jumping, squatting, that kind of stuff. Doing all of that as often as possible is going to be very helpful for maintaining those connections and the health of the neurons and the connections between neurons and from neurons out like to skeletal muscle. Okay? So if you guys are catching a theme here, it's basically everything goes to shit as you get older. But if you will maintain activity and use of muscles and the nervous system and keep loading your skeletal system, we can prevent a lot of changes. Okay. It is almost noon. Let's take a break. We'll take a 7-minute break. We'll come back and we'll start up again at 12:05, and we'll start talking about kind of more of this declines in strength. Okay. So I'm going to stop share. I'm going to resume recording. So we're rolling again. Okay. All right. So we've talked about declines in strength. We've talked about declines in muscle mass. Okay. We've talked about changes in the kind of skeletal system, like in bones and connective tissue a little bit. We've talked about a little bit of the changes on the nervous system side. Okay. So what everybody needs to appreciate from this, okay, is that declines in strength, and this is the big kind of piece of this, and the associated decline in muscle mass is not going to be uniform across all muscles in your body, okay? You are going to see with aging, much like we have with everything else, that the idea of if I don't use it, I will lose it, that philosophy is really going to be borne out, okay? It's really going to be borne out when we get to talking about aging. And so you're going to see greater losses of strength in muscles that you use very rarely, okay? So you're going to see kind of greater losses in those kind of silly things that the bros like to train. Like we tend to lose strength, like our bench press strength is going to go down, more rapidly than, say, your plantar or dorsiflexor strength is going to go down, or even then your bicep or tricep strength is going to go down, or probably even your quad strength, okay? Muscles that we don't use in everyday life, or movements that we don't do in everyday life that often, are going to be the movements and muscles that are going to tend to lose strength, okay? I don't really get into this too much in this particular class. I think Dr. Mike talks about it more in exercise phys, but we tend to see a greater loss of strength when we perform concentric muscle contractions versus isometric or eccentric contractions. It's really beyond the scope of our class for me to try to, and we need to spend a half an hour or so kind of talking about why that's going to be the case. But that's kind of where we are. We tend to lose strength more so during very fast contractions. A lot of this is going to be due to the loss of type 2 muscle fibers. In addition to that, as people age, because when we do things that go really fast, they sometimes require high amounts of force, or they tend to have been associated with playing sports and things like that. People that are older just don't do things that go very fast, okay? Many of you guys may think, oh, well, whatever now, I play intramurals, I do things, I run, I sprint, I jump, things of that nature. Maybe many of you even I still, I go to CrossFit or I dance or whatever it might be. You're doing things that oftentimes require you to move pretty quickly, okay? As you get older, the necessity of doing that in everyday life is going to go away, right? It's going to go away. You may not have anybody to play your murals with, okay? Now, if and when you have children, you have to run around quickly to catch those children, or to make sure they don't do like a nosedive off the playground like Ellis almost did yesterday and things, but you tend to not do those kinds of activities, and so you lose kind of your accumulated wealth of training on how to go very fast, okay? Excuse me. And these data have tended to kind of normalize a little bit. But if you are a woman, in the past, you tended to lose more strength than men as you aged. But a lot of that was due to societal norms on physical activity and things, and a discouraging of women to maintain activity, discouraging of women to do especially resistance training as they age and things. And that has normalized a reasonable amount. Other pieces of it too is that people that work more manual labor-ish jobs where they have to generate lots of force as part of what their job is, which have traditionally been more male-dominated professions, tend to have less declines in strength with age, whereas women have tended to be more of the office jobs, somewhat more sedentary jobs, things where you're not out, building fences and houses and those kinds of things, although there has been some shifts in that as well. Okay, so let's talk about how we can use physical activity to attenuate a lot of these diseases, okay? Why does Grandpa with his awesome mustache, I didn't pick out these pictures, Dr. Pinku did, but why does Grandpa need to be deadlifting? Okay, what's in it for him? Why and how is that going to be a good thing? Okay, so let's talk about strength training. Now, one way to do all of this if you want to strength train when you're elderly is basically to just do what Sylvester Stallone does in our picture here and just take steroids, okay? We will talk about this in a few slides. We'll talk about it tomorrow when we talk about osteoporosis, but one of the things that changes with age is men's testosterone declines and women after menopause, estrogen declines. If we just give you back those hormones, then we can prevent some of these losses, okay? However, we've not really worked out a super good way of doing all of that we are certain is 100% safe, okay? Now, guys, you can go to pretty much any strip mall anywhere in the country and find a male enhancement clinic where they will be happy to provide you with erectile dysfunction drugs, hair loss drugs, or hair implants, and potentially under a prescription some testosterone supplements, like actual replacement of testosterone that will get you closer back to a physiological level. Women, you can take, I think still, it is still approved by the FDA, you can take hormone replacement therapy. My mom was on it for a while and then got off and then got back on until you kind of clear menopause. The hot flashes were too much. She figured she would brave the increased risk in breast and uterine cancer from taking those hormones and those things. Okay. So in the absence of taking some kind of hormonal replacement, the one thing that we can do to prevent the decline in muscle mass and to prevent some of the decline in strength is to perform strength training in older adults. Okay. Send grandma and grandpa or send mom and dad to the gym and have them lift weights. They may want to start off lifting lighter weights and things, but there's no reason why they should not lift. Okay, they shouldn't lift at a pretty heavy amount of weight. As we mentioned before, there's this very strong use it or lose it kind of disuse thing that's going to come in. Okay, when we undertake resistance training, it can and will be very, very effective. You can not gain muscle mass, but you can prevent the loss of muscle mass. You cannot gain strength, but you can prevent some of the loss of strength. Or for most people up into maybe their 80s or so, if you do strength training correctly, you can increase strength and you can definitely increase muscle mass, whether you've ever done strength training in your life or not. Okay. So there's lots and lots of benefits. Okay. Improvements in mobility, activities of daily living, all of those are going to contribute to functional independence. You're going to have better balance. You're not going to fall down as much. It's going to improve bone mineral density, which we will talk about on Wednesday. Really, really big thing for women, especially postmenopausal women, is to do things that load their bones. They need to squat. They need to do military press and things where they get up over their head so that they can actually load the spine and keep their vertebrae healthy. They need to run and jump and do things like that in an effort to kind of load those bones. It's good for men and their bone health as well, but it's a little less important because they don't lose quite as much mineral density. And then depending upon how sedentary you are, there are going to be some benefits for resistance training from your metabolic health. It's good, one, for type 2 diabetes. It's going to have some of the same positive outcomes of improving insulin sensitivity and glucose tolerance and skeletal muscle as running or walking will do. But also, if you're very, very untrained, then lifting weights is actually going to get you a little bit of an increase in VO2 max, and that can be a very, very positive kind of thing. Okay, so there's a little bit of data in here, and you guys don't have to know the study. You don't have to know the citation for the study. You don't have to know any of the kind of real things in here. We are just showing this to you guys to try to highlight some of the research that has been conducted, and there's been a bunch in aging. Some of the research that's been conducted that has led us to these conclusions that performing resistance training has these fairly sizable benefits for you, okay, in older adults. So here is this Fiatarone study. They had 10 older, frail subjects. So this is grandma and grandpa, 86 to 96 years old, very frail. So they're weak. They have low bone mineral density. They all lived in a retirement home or a nursing home. And they had many, many chronic conditions, okay? OA stands for osteoarthritis. Most of them had arthritis, osteoporosis. They were hypertensive. They had coronary artery disease, okay? So these were folks that were old and they were doing okay, but they had lots of comorbidities. And so they had them do only 8 weeks of progressive resistance training. All they did in them was knee extension exercise. So sit in the knee extension machine, put the weight on down here, press against it, and then just do knee extensions. They did 8 reps for 3 sets at 80% of their maximal strength. So a pretty standard resistance exercise prescription. This is in these older folks, okay? In 8 weeks, they increased their knee extensor strength almost 200%, okay? They got a lot stronger, right? They had this continuous increase in strength throughout training. There was no plateau. And this increase in strength led to about a 50% increase in their walking speed. 2 of the 10 people no longer needed walking aids. 3 of them went from not being able to get up out of a chair to being able to get up out of a chair. And so there's this very marked decrease in functional disability. Okay, so even in these very, very old, very frail older adults who are in an assisted living home or in a nursing home, this very simple resistance training program, just of the knee extensors, had very, very profound positive impact on them. Okay? So what you can see then, I kind of talked about that. Yep, this was one of the first studies, okay, that really told us that we needed to do things. So here we have an old picture of Arnold Schwarzenegger, and the question is, well, in older adults, they were doing 80% of 1 rep max. Do we really need high intensity? Right? You can make an argument that having a 95-year-old person trying to lift 85% or 80% of their 1 rep max is potentially dangerous. Now, this was a knee extension exercise. They were sitting in a knee extension machine, and so they were limiting their range of motion. It wasn't free weights and things. So they did some things to take care, but you can make an argument that maybe you don't need high intensity. Maybe higher intensity is going to discourage them, and it might be dangerous. Not everybody is going to be like Arnold. Okay, so there's been additional studies. One where there was 3 months of low intensity training, okay, or lower intensity training. Say this 40 to 50% of 1 rep max, 5 days per week. And they found that that improved balance and mobility as well as strength in some older female participants. So there's evidence that it doesn't have to be 75, 80, 85% of 1 rep max. Although there's plenty of evidence that if done correctly with the proper form and the proper precautions, that older adults, they can do the higher intensity stuff. It's not going to be that big of a problem for them. But you can get some similar increases in these lower weights as well. Oftentimes now, when people talk about prescribing exercise or resistance exercise in older adults, it's start with these kind of lower percentages and do a month to 2 months doing that, and then bump them up into the higher intensity stuff. Okay? So if you wanted to train older adults, right, if you were going to make some suggestions to, say, your grandparents, or when I make suggestions to my parents, whether they listen to us or not is in some ways irrelevant. Things that we need to be aware of and appreciate, and I do want you guys to know these things because there will be questions on the test about this, okay, is most older adults are going to have some kind of chronic condition, okay, in addition to being over the age of 45 or 55. So at best, older adults are going to be moderate risk on our ACSM risk stratification. Most of them are going to be considered high risk. So what we need is they need to go and get a physician's consent to be able to perform the exercise, okay? We, if all possible, want to avoid having them do the Valsalva maneuver. So we want to teach them how to breathe throughout the exercises to try to limit the increases in blood pressure that take place with Valsalva. They're going to talk about needing a longer warm up and a longer cool down. I think you guys know very well how I feel about warm ups and cool downs, but it's probably not a terrible idea in them to go ahead because they have joint issues, to go ahead and try to warm up a little bit better and maybe do a little bit of cool down. It's important in older adults to also, in addition to just doing weight training types of things, to try to incorporate things that are going to be functional. Have them practice doing sit to stand. Have them practice walking up and down stairs, or have them practice doing things where they reach up over their head and get things that might simulate pulling something out of an elevated, let's just say, cabinet and pulling it down. Or similarly, having them bend over and pull something out of a cabinet that is kind of down near the ground. It's going to simulate what they might do to get pots and pans out, or to get cans or glasses or things down, depending upon how where their living is going to be set up. It's important to do multi-joint large muscle group exercises. We really want to, in these individuals, work on back muscles, shoulder muscles, okay, legs. We really, really want to try to hit those large multi-joint exercises because those are the things that are going to be really predictive of their actual function, okay? Especially initially, machines are going to be preferred over free weights because they require less skill and they are safer because there's more support provided. They can lock in the range of motion that can be used. They're going to provide a lot more safety. What you're going to find is that older adults are going to tend to have potentially balance issues, and they're going to have issues with their accessory muscles, and so they're going to have a hard time kind of holding weight steady and doing all of that. So starting off doing some machines that limit their range of motion is going to be really, really helpful. Okay. All right, let me check how we're doing on time. We got plenty of time. Okay. So lots of big changes in resistance training and in the musculoskeletal system. Okay. Many of you also called out that there's going to be changes in aerobic metabolism, especially in VO2 max. Okay. And indeed, for a host of reasons, that is one of the other kind of hallmarks of aging, is a decline in aerobic fitness. Okay. VO2 max tends to decline about 5 mLs per kg per minute per decade. Okay. And a lot of that is going to be due to this 10 beat per minute decrease in maximal heart rate. So as maximal heart rate declines, maximal cardiac output is going to decline with aging. And I want you all to keep this number in mind here. Okay. So there is what we think of as a kind of functional threshold. You need a VO2 max of somewhere in the low teens to about 15 mLs per kg per minute in order to be able to get up out of a chair, to walk around slowly, and perform just kind of your normal, very, very basic activities of daily living. Okay. To be able to walk around, to cook, to clean, right, to take a shower, those kinds of things. The very, very most basic thing that all of the rest of us take for granted, you need about this much to do those things. So if your VO2 max is declining about 5 mLs per kg per decade, you can imagine, all of you all measured your VO2 max, or we estimated it using your walking distance. If you had a VO2 max of 35, let's just say mLs per kg per minute, then it's going to take, right, in 4 decades, you're going to be right at about 15. Okay. So in 4 decades, you're going to be 60. So by the time you're 60, if you don't do anything, then you may have a decline in VO2 max to where you're very, very close to this functional threshold. Okay. So that's the big issue. That's why we want to try to limit or mitigate or attenuate as much of this decline in VO2 max as we can. Some of it is just inevitable. Okay. There's going to be an increase in vascular stiffness due to atherosclerosis that's just going to accumulate. That's going to make moving blood around a little bit more difficult. We do tend to see some age-associated weakness in our respiratory muscles, which is going to limit minute ventilation, and it's going to lower our ventilation. There's going to be stiffness of the intercostal joints. So again, there's going to be a little bit of a change in the respiratory or in our ventilation. So breathing becomes a little bit more difficult. We can't bring in quite as much air that way. We're going to get a decline in maximal heart rate. So cardiac output is going to go down, and we're going to have some increases in vascular stiffness. And so that's going to lead to a heightening in blood pressure. And so we're going to have a little bit of issues that are going on circulating blood flow because of that. So some respiratory changes, some cardiovascular changes that are going to contribute in some ways to this. Okay, so it's going to be more difficult to bring in the oxygen and get it to the muscles. Not to mention, as we lose muscle, then you're losing strength and you're losing muscle that can actually use all of those things to help us move ourselves around. Okay. Okay. So what we're going to see, here's data from men, here's some data in women. Okay. And this is data that we obtained in some relatively highly trained individuals. Okay. So I just want you to see kind of what that's going to look like in highly trained individuals. So we have people, these are men that have a VO2 max of almost 60 at the age of 45. Okay. These are dudes that would absolutely obliterate me trying to run a 5K or a 10K or just walk across the street right now. And they followed these guys. Okay. They continued to train. So these are highly trained aerobic athletes that continued to train well into their 70s and 80s. And then they were kind of cross-sectioning some of these guys, and they were following some of them that stopped training, okay? And you can note these are the guys that are going to be here. So the ones that stopped training had a more steep decline in VO2 max. But I want you to appreciate that even if you were super highly trained at 45, you're almost at 60, right? A lot of some of those people by the time they're out here are going to be under 30. So they've lost half their VO2 max. Similar thing here in women, okay? These are people that are at 60. The vast, 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 vast majority of us were nowhere near 60 at any point in our lives, okay? Many of you guys, as you noted, kind of an average college student that's a guy somewhere between, about 40 or thereabouts. An average college age woman is about 35 to 40. So you've got a much, much shorter range to decline before you get near that functional threshold, okay? So, but what I also want you to see is that if you continue training, you can train yourself and stay at this very high level, even, out here to a fairly elevated age. I'm not quite 45 yet, so I guess I could conceivably train a bunch and maybe get myself back kind of near to something like all of that. I think when I was a grad student, my VO2 max was about 61 mLs per kg per minute, but that was like 30 pounds ago. So that's a kind of a big issue for me. So we can train some of this, but you can maintain a lot. There's going to be some inexorable decline because of some of the age things, but we can stave off a bunch. Okay. This is Dr. Pinku's father. They live in Israel, and they were out here kind of doing this race every year with some things. So he always likes to show and kind of talk about him. What I want to illustrate, or what we want to illustrate with these data again, are people that were, that were runners, okay? These are going to probably be men that were runners initially, okay? Have a VO2 of about 70, so these are very, very highly trained, like 20-year-olds. Here we have untrained, so they're probably all men, highly trained, like cross-country runners in college, untrained college males, and then kind of well-trained, but not like elite kind of folks. And what I want you guys to note is these are people, here's our untrained person that doesn't do much. They're going to decline. We're going to see this decline in our people that were continuing to train at a high intensity as they're aging. And then we're going to also have these folks that are gonna lose some as they drop their intensity down. And then here's our folks that were super duper trained that basically stopped doing everything, and our green ones, they kind of maintain what they were doing. And so you see this giant decline that we're going to see right here, but they're still not as bad off as our people that were this way. Okay, so there's something to say for go train as much as you can now, because then it's going to be high. And if you never do anything else for the rest of your life, you're still going to be in a better place than people that have never done anything. But probably the better way to think about this is do as much as you can now, and then try to continue to do as much as you can as we age over time. Okay. Similarly to the resistance training, there's this idea of use it or lose it, right? You can induce cardiovascular and respiratory changes and mitochondrial changes and capillary changes and things in and around skeletal muscle. So training when you are older can be very, very effective. Okay, you can maintain things as you age, and then even if you've never done things, you can take an older individual who is not in very good shape, have them do training, and they will improve. Okay, this picture here is of a fellow named David Kostel. He is one of the most famous exercise physiologists in the world. He's in his 90s now, and he still runs marathons every year. We should all be so lucky. Okay, so benefits of training. We're going to attenuate the decline in VO2 max. That's going to be a big, big one. Okay, we can attenuate this decline by attenuating the decline in stroke volume and cardiac output. We're going to have improved mobility, better performance of ADLs, lower risk of falling, improved metabolic health. So it's going to be good for folks that are at risk of becoming a type 2 diabetic or that are type 2 diabetics. It's going to improve insulin sensitivity. Okay. Where are we with this? It's 12:30. You know what? We're going to stop here, guys. So we will pick up talking about this next bit of stuff because it's going to require a little additional explanation. This is something called functional independence and physical performance test. that I'm going to see if I can find a video of this for you guys. This was developed by a woman named Elaine Kress, who was on the faculty at the University of Georgia when I was a grad student there. But it's a way to test older individuals, really anybody in the lab, and show you kind of how VO2 max and how maximal strength and things is going to be associated or potentially related to performance of everyday activities like making your bed or folding laundry or carrying groceries or something. And so it requires a little bit more explanation, and we've got plenty of time left for class in the next couple of weeks. Okay. All right, so I'm going to, so we will pick up there. Do that.